Welcome to the Senior Moment. This is Connie Clark with Home Helpers. And this afternoon in the studio with me, I have Doctors Michael Coates and Dr. Dave Ramey. And they're both with the Kootenai Sleep Disorders Center. And I know this is something that all of us have had an issue with at least one time in our life. But there are actually medical conditions that cause us not to be able to sleep at night. And these doctors help find out what it is and what we can do to fix that. So welcome.
Thank you.
Thank you.
So first of all, tell me, is it normal? I guess, what is a normal sleep pattern? So then we can define what an abnormal sleep pattern is. So what is, you lay down, you immediately go to sleep, you sleep for 8 hours solid and then wake up bright-eyed and bushy-tailed? Is that what we're all supposed to be doing?
Well, I think that's the goal for everyone. I think everybody sleeps a little different. Everybody requires there is some variance between sleep requirements, but for most human beings, 7 to 9 hour range is what most of us require. So there is some differences there, but we all fall within that period of time for the most part.
Okay, let's start with the process. If you don't fall asleep within X period of time, then there's an issue. What is X? How long is that?
Well, we usually tell people that we don't like people to lay in bed trying to fall asleep usually for more than about 30 minutes.
Okay.
If that's a chronic problem, then we usually investigate some of the reasons why that may be.
What would some of those be?
Well, insomnia being the most common thing, there is something called psychophysiologic insomnia, which is probably the most common cause of insomnia, and those are the type of people that have difficulty turning their mind off. Is a common description at night before bed.
That sounds familiar.
Mm-hmm.
Okay.
So, we try to investigate some of the things that they may be thinking about or causing them difficulty or causing them anxiety as they're trying to go to sleep, and then work on some things to combat that.
And what if they're not thinking of anything at all, but they're still unable to sleep? Is that when you all would step in with some remedy, or?
Yeah, we would, investigate or give some recommendations regarding relaxation techniques, or really look into some other things like restless leg syndrome that could possibly be contributing to their difficulties with sleeping as well.
Now describe what that is.
Restless leg syndrome is a very common condition that can affect people of any age, but it's a vague, uncomfortable sensation in the legs that people often describe as bugs crawling on their legs, or a tight feeling, and it really can affect people to the point where they have to get out of bed frequently and walk around. The symptoms are usually at least temporarily improved with movement, but it really can affect people's ability to fall asleep.
And so there's things you can do to stop that from happening?
There are medications that can be used to treat it.
Now, is that something different than, because I have seen, like in my husband, where he twitches and stuff at night. Is that something totally different, where his legs jerk at night?
So there's a whole variety of reasons why people's legs twitch at night. You certainly can see that with restless leg syndrome, but also patients who have untreated sleep apnea will oftentimes twitch at night, or people who are just having an uncomfortable night's sleep will twitch. So that, as Dr. Ramey said, many people who do have restless legs do twitch at night, but not everyone does.
Okay, so you've mentioned sleep apnea. That is something you hear all the time, people talking about. Describe what that is.
So sleep apnea is a disorder where individuals will periodically stop breathing at night. We all probably stop breathing once in a while at night. Almost every adult has an occasional apnea. But if you stop breathing for more than 10 seconds at a time, and if that occurs more than 5 times an hour, we think that represents a medical problem. It can cause problems with your subjective quality of sleep. It can make it hard to fall asleep and to stay asleep. But also over time, it can actually cause medical problems. If you're not breathing at night, you're not bringing in sufficient oxygen. And if you don't bring in sufficient oxygen, it's harmful for the brain and the heart over time.
So when you stop breathing, it's not enough for a health event, but it's what, 2, 3, 4 seconds?
Normally, when people breathe at night, they may go 3, 4, 5 seconds all the time without breathing, just a normal respiratory pattern. They may even go more than 10 seconds on occasion. But if they go more than 10 seconds at a time, more than 5 times an hour, that's what we call sleep apnea.
Okay, and what do you do about that?
Well, there's a variety of different things that you can do for it. Sometimes it's a matter of correcting some medical problems or a medication side effect that the patient's having. But if those issues are addressed and they're still having problems, then you need to somehow keep the airway open, because the problem with most people with obstructive sleep apnea is that the airway is closing off. That can be either with a breathing machine called CPAP, which is covered by insurance and is probably the most successful treatment. There are dental devices that work to pull the lower jaw forward, opening the airway. Weight loss is helpful for people with sleep apnea. And then in a select group of people, they may need surgery even to enlarge the size of their airway.
One of the things that you said might be causing that is reactions to medications. What kind of medications would cause you to stop breathing?
Well, there's several classes of medications that can stop you from breathing. One, the so-called opiate or narcotic pain medications, things like hydrocodone, OxyContin, depress respiratory drive, as do some muscle relaxants and sleeping aids. Some of the sleeping pills that are based on benzodiazepines, such as Halcion, Dalmane, temazepam or Restoril, and some of the tranquilizers that folks take, like Valium and lorazepam. Xanax can depress respiratory drive.
So they rest you so much that you don't breathe.
They
relax you so
you
much.
don't breathe. The other agent, not really medication, but the other drug out there that depresses respiration is alcohol. And so one of the things we strongly recommend is that people not have a nightcap or use alcohol excessively at night, because it decreases their respiratory drive and also relaxes the muscles of their upper airway, leaving them more prone to have apneas.
Interesting. So if you find out that you are stopping breathing, if your spouse or whoever you're with tells you, I've been listening to you breathe at night and you're stopping breathing, what do you do? I mean, where do you go? Do you just go and tell somebody, or what?
I think a great place to start really with all these different sleep disorders is probably with the patient's family doctor or primary care provider. Lots of times there are other medical conditions that could be interfering with sleep, such as heart disease, lung disease, bad back, bad hip, things like that. Even acid reflux can interrupt your sleep. So I think those are probably best brought up originally to your primary care provider. If they feel that there's a problem with a sleep disorder, such as like restless leg syndrome or sleep apnea, they may address that themselves, or they may refer the patient to Dr. Ramey or myself for further evaluation.
So you shouldn't, if you're not sleeping at night, you shouldn't just run right out to the sleep center to see if there's an issue. There could be other things you could do
Absolutely.
that could alleviate that without having to go through all of that.
Yes. Not everyone that can't sleep well needs a sleep study. Primarily what the sleep studies are done for is to determine if someone has sleep apnea or not. But oftentimes you can diagnose the sleep disorder that the individual has without a sleep study.
Just by asking them questions of what medications they're taking or
Yes.
what their eating or drinking habits are and that sort of thing?
Yes.
Okay, so what if I'm not taking any medications, I don't take sleeping pills, I'm not drinking, and I wake up at 2 o'clock every night? What would do that?
Well, a lot of things can do that. I think if there's no, as Dr. Coates said, after a visit with the primary doctor, and there's no obvious medical explanation or medication, offending medication that could be causing problems with sleep, then I think at that point it makes sense to see a sleep doctor to really delve more into the sleep and really try to figure out what else could be going on. I think that nighttime awakenings are a very common problem for a lot of people, it's not necessarily abnormal to wake up during the night, but if there are other things to suggest that sleep apnea or leg movements or something else could be causing it, that's the point. At that point, we usually will consider potentially an overnight sleep study to evaluate that.
Now, I know a lot of seniors, all of a sudden, their sleep habits are changing, due to their medical conditions and that sort of thing. As you get older, do you require less sleep or more sleep? Because I've seen it in both situations where they only sleep 4 or 5 hours, and then I've seen it where they sleep 10 to 12 hours. Which is there a normal, or is that something that just comes with age?
Well, we know that sleep changes as you get older, what we
Okay.
call sleep architecture, the amount of sleep that you get in different stages as you get older decreases. So unfortunately, as we get older, our restorative sleep, particularly our deep sleep, tends to become a little bit less than it was when we were younger. So the amount of sleep time doesn't necessarily change, but when we sleep tends to change as you get older. So older people and senior citizens often tend to be what we call phase advanced to some degree, meaning we go to bed a little bit earlier and they tend to get up a little bit earlier. Whereas when we're younger, it's sort of the opposite. So sleep definitely changes as we get older.
Now, in reading the information on the pamphlet here about the sleep disorders, and it talked about the different things that you all look at when someone comes to your center. Talk about if someone has already gone to their primary care physician and none of these pre-existing or other conditions are going on, and they need to have a sleep study. Tell me about what that process is.
Well, a sleep study could be ordered either by their primary care provider or by a sleep doctor like Dr. Ramey or myself. There's two types of sleep disorders, and we use them for different reasons and according to what the individual's insurance company's preferences might be. There are home studies, which are a unit that we're able to send folks back home with that they can use at night and use in their own home. That has the advantage of being more comfortable for some people because it's in the context of their own home. On the other hand, of course, there's more limited data from that. So for individuals who have a fairly typical history of obstructive sleep apnea, that is a reasonable course to take. We also do sleep studies in the sleep lab, and there are certain individuals where the more data in the sleep lab is actually very helpful. People with known heart disease, people with significant lung disease. Also, the home studies are less sensitive, and so people who have subtle sleep apnea, particularly children who have sleep apnea, oftentimes do not do very well with the home studies. In the cases where we're looking for something other than sleep apnea, sometimes we see people who are having unusual movements at night, maybe even possibly seizures, things of that sort. For those patients, you really do need to do the in-lab study.
You had mentioned children. What percentage do you see of children that come in with that problem? Because I never even considered children having issues sleeping.
Well, I don't know exactly what the percentage is, but there's a couple of reasons why we do see children, particularly children with sleep apnea. One is that unlike adults where obesity is a common cause of sleep apnea, in children oftentimes enlarged tonsils are a major cause of sleep apnea. So we do see children who are of normal body build who snore excessively, which is unusual for a child, and do turn out to have large tonsils. And if that's associated with a medical problem such as sleep apnea, then it's probably reasonable to have the tonsils taken out. Also, just a change in our society as time goes on, children are getting bigger. There is more obesity in children now than there used to be.
Why? It's probably a stupid question, but why would obesity? Is it just the physical largeness, or is it something that obesity does to our internal organs?
There's probably two things that obesity does in regards to breathing. One is as we gain weight, some of those fat deposits are up in the neck area, decreasing the size of the airway some. Another issue is as we gain weight, particularly as we gain weight and then we lay down to sleep, the abdomen and the abdominal contents actually press up against the diaphragm somewhat, decreasing the amount of bellows effect or the degree of excursion that your rib cage can make, so that people literally cannot create as much suction. So it decreases the amount of airflow, both because of the size of the airway and reduced ability to expand your lungs.
And then how would, if you had a heart condition, do that? Is it just that the heart is having trouble keeping up beating, or
The heart can affect the breathing in several ways. Individuals who have what's called heart failure, where their heart is less efficient at pumping, there does tend to be a bit of accumulation of fluid in the lungs, which then makes the lungs less efficient and can make the breathing more problematic for individuals.
okay, that makes sense. So if I went in, let's say I was going to do, let's start with the home part, which I know a lot of people would say, oh, yeah, I'd rather do that because I don't want to go sleep and have people watch me sleeping. What do you measure, and how is it hooked up, the diodes or whatever, on a person if they were to have this at home?
Well, as Dr. Coates mentioned, a home study is a bit more limited. The main difference is that with a in lab or in the hospital sleep study, we monitor brainwave activity, and that's how we determine what stage of sleep somebody is actually in. We are not able to do that at home. So what we do monitor at home is airflow through a cannula or a thermistor that monitors the amount of air that somebody's moving, as well as chest and abdomen movements. We monitor heart rate, oxygen saturations, and also for leg movements. So the main difference between a home and an in-lab study is the lack of brainwave electrodes or EEG electrodes.
To see if how many times you're actually going into the deep sleep.
Right. That's the one thing that we don't know is what stage of sleep somebody is in with a home study.
Okay. Well, we need to take a break, but I want to continue asking questions about this because I know a lot of people often wonder, you see on TV someone standing behind a class watching you sleep, and if that's the real thing. So we're going to take a break, and we will be right back.
Dr. Coates stays at the lab and watches
I
people
do. I
sleep.
stay up and I wear a little,
He never
like a little
sleeps.
camouflage like in the
Got
Sharp
something the
Nose
same
movies.
color as the wall, and you
No, sleep studies have evolved. There was a time where they, in fact, did do that. And when I first moved here in the late '90s, the sleep lab actually still had an old two-way mirror, one-way
Yeah,
mirror, I guess
yeah.
they call it. Where you can
Right.
and they no longer use that, but that was still the architecture. Now the technicians sit in a room adjacent, but not connected, and they what they're watching is the electronic data on a computer
Not a
screen.
video of the person.
Typically not. We do have a closed circuit TV just to see if the patient's having any distress or any problems like that. But that's not what we're getting the data from.
Okay. Okay.
Yeah.
Yeah, I thought I'd throw that out there because
Yeah.
I'm sure that's the picture I had
Yeah.
in my mind. So, okay. Are you ready to go back then? She's going to get you. Okay, you want to wait a second? Then? No, that's okay. That's okay. See, we're just having to sit and talk about.
Well, these are patients. These are questions that patients ask.
Yeah, I know. That's what I said. It's probably stupid questions, but it's things everybody wants to know.
As long as you don't ask about dream interpretation.
Yeah, I was telling Dave when
It's a
I've
common question.
done call-in shows for NPR and PBS,
Uh-huh.
and people call in with questions like, "I had this dream. What does this mean?"
Oh, no.
Or one person called in and asked, "Do my plants, do they sleep? And is there a way to check that out?"
Well, there's, no, we're not going to have any weird people
Yeah.
call.
Yeah.
No, I know about this much about it because my nephew wears
CPAP.
CPAP, yeah. And my husband snores, so. But yeah, I want to go into you've described what the home monitoring is like now. I'd like to get some information of what it's like when you come to the sleep lab. And I'll throw out, my picture is there's men and women with white coats standing behind a mirror watching you, and you can tell me what you did. No.
Wear blue coats and little propellers on their heads. Night vision goggles.
Yeah, there you go.
Thank you. Thank you very much.
Ready? And we're back. Welcome back to the Senior Moment. Again, this is Connie Clark with Home Helpers, and I have Dr. Coates and Dr. Ramey here with Kootenai Sleep Disorders Center. And we've been talking about sleep disorders and what kind there are and the different ways of checking to see what the problems are. And we ended talking about the method that is used now for monitoring someone's sleep patterns when they're at home. But there's also where you can go into the lab. And I kind of jokingly said during the break, well, my picture is what you would see on TV where you've got, people in little white lab coats standing behind a two-way mirror or a one-way mirror standing looking at the person sleeping or getting ready for bed. And, how can you sleep when you've got someone standing there watching you? But you were telling me that's not exactly true. They wear blue, right?
Wear blue coats rather than white coats. Well, actually, there was a time, although that time was probably in the 70s or 80s, where they would actually watch someone sleep to get the data. But for the last 20-some years, the data that we use to interpret the test is really based on the electronic data that we're getting from the patient. There are surface electrodes that are simply either pasted or taped onto individuals that monitor their breathing, their brainwave activity, things of that sort. And the technicians are in a room that's close enough to the sleep room so that they can be of assistance to the patient if they need it. But it's not, the technicians are not actually in the room. They do have a closed-circuit TV so that they can check on the patients if they seem to be in distress. But what the technicians are actually watching is the electronic data of the brainwave activity, their oxygen level, their EKG, and the respiratory pattern. They're not actually just sitting there watching the patients at night.
That was my picture of it,
You bet.
With all of that on you, can you still move around?
You can, a lot more than people think. We've been doing this for a long time, and so there's a lot of improvements in the technology of the sensors so that they are on fairly securely. And so a patient can move around quite a bit without them becoming dislodged. In the event they do become dislodged, it's no big deal for the technician to simply replace it. The technician is sitting there watching the electronic data. It's very obvious to them if an electrode becomes dislodged. Patients who are set up can get up and use the restroom. I've had patients actually get all hooked up and then realize they left something in their car, and they've gone out to the car and gotten it and come back. So individuals are a lot less encumbered than they think they're going to be with it.
Is it wires coming from all of them, or is it all radio transmitted?
It's wires coming out of the sensors, and then those wires all plug into a little junction box that's about the size of a pack of cigarettes or a couple decks of cards. And then there's another attachment to that. So once someone's hooked up, you can just detach that junction box, which is just this little small box that then the individual can get up and walk around and do whatever they want.
So you don't have to unplug everything.
Absolutely. You do not have to unplug everything.
And the data that you get, you said that you're looking at the brain waves, the respiratory, all of that. How do you use that to interpret what the issue is? Give me some examples.
Well, so say for example, someone who has sleep apnea. In sleep apnea, as we already mentioned, an individual will go more than 10 seconds without breathing, and they'll do that more than 5 times an hour. In addition to that, there's other types of sleep apnea. There's obstructive sleep apnea, the most common, where individuals will stop breathing, but they'll be attempting to breathe. So we'll see respiratory effort, but we don't see any airflow. There's also central sleep apnea, which is less common but not rare, where not only do individuals not move air, not only are they not breathing, but they're not breathing because they're not initiating a breath anymore. And so there's the two types of sleep apnea, and in terms of treating it successfully, it's really essential to know which type you're treating.
Okay, we all know about the CPAP, which is the mask you wear, and that's just oxygen going in, correct?
It's actually just compressed air.
Okay.
If most individuals who have sleep apnea, if you can get enough air into their lungs are able to extract the oxygen out. The problem for most people with sleep apnea is that they're simply not breathing.
So if you've got these different types of sleep apnea, what different methods would you use to correct it, or would it be the same method?
Well, there are different types of machines. So CPAP being the most widely used, and CPAP is uh, the acronym is continuous positive airway pressure. So you're getting a continuous set pressure at all times, whether you're breathing in or whether you're breathing out. Uh, Another commonly used type of machine is something called BiPAP, which just looking at the machine looks very similar to CPAP, but it works a little bit different. And patients that have, as Dr. Coates mentioned, central sleep apnea tend to respond better to that type of machine. And the main difference is that there's two pressures. There's a pressure when you breathe in, and then there's a pressure that lowers a little bit when you breathe out. So patients that require higher pressures to keep that airway open, they often respond better or tolerate BiPAP better.
So the air is actually being pushed into your.
Yes, it's
Okay.
it's a continuous positive pressure.
Okay. So you would use different pressures and different types of pressure for different types of apnea?
Yeah, and everybody, people have different pressure requirements. So some people require, a pressure of say 6 or 7, whereas as some people, in order to keep that airway open, may require pressure of 14 or 15. So that's something that we also can see in the sleep lab when we use CPAP in the sleep lab.
Now, one thing that I have an issue with is snoring. I snore, my husband snores. And how does that keep you awake? And if you see somebody snoring, what do you do about that?
Well, primary snoring can be disruptive to the bed partner as well as the patient.
It can
Sometimes they wake themselves up snoring. Snoring in and of itself doesn't guarantee that somebody has sleep apnea, but it's a sign of it. Snoring indicates turbulent or disrupted airflow, which you can see from narrowed airway or which is probably the most common cause of snoring. But snoring is a very common problem that can be treated with CPAP or with, more commonly nowadays, for people that just snore, dental devices are very effective to treat that as well.
Yeah, I saw in the Kootenai Health magazine, they were talking about a dental device that moved the bottom jaw forward. Is that what you're talking about?
Yes. Yeah.
And what would that do? Change the structure of the throat? Or
Well, it opens up the back part of the upper airway, so
Okay.
it doesn't sound like it would do that, but it actually opens it up quite a bit to the point where it increases flow enough to where the turbulence of the airflow is decreased and the snoring is decreased.
And what you were talking about, someone being overweight and the fat around the airways. So would that, if someone didn't snore and then gained a lot of weight and started snoring, would that be the reason for that?
That would possibly be one of the reasons for that, absolutely. The muscles of the upper airway hold airway open. And when we fall asleep, those muscles relax, and then they, as Dr. Ramey said, the airway narrows. You get the turbulent airflow that causes vibration, and then that's where you get the snoring from. It's a continuum, so that if the airway actually closes off, if it closes off for 10 seconds, then that's the apnea. The way the dental devices work, and many, I think, of the listeners have probably taken lessons in CPR. They teach you to pull the jaw forward to open the airway. The tongue's attached to the chin, so if you can pull the chin forward, it will open the airway. Many patients actually kind of intuitively know that. They know if they pull their tongue forward that their snoring's better, but of course you can't sleep and do that at the same time, and so that hence the dental devices.
Now, one of the things you said you also monitor is brainwaves. Now, if you see someone is not having the deep sleep a lot, what does that indicate?
That can be due to a lot of different things. we see that in patients that have sleep apnea because the deeper stages of sleep, particularly REM sleep, during REM sleep, for a normal person, most of the muscles are actually paralyzed. They're completely paralyzed. And when that occurs, patients that have sleep apnea, things tend to relax more, and the apneas are much more common during REM sleep. So we see patients that have chronic sleep apnea that get much less REM sleep than a normal person. So medications can also be a big factor in changing the sleep architecture.
And in the brochure that I looked at, you were listing all the different sleep disorders. You were talking about obstructive sleep apnea, snoring, insomnia, which we talked about not being able to go to sleep, period limb movement disorder, and that's the restless leg that we had talked about, and narcolepsy. How does narcolepsy, explain that to me? Because I really don't know what that is.
So narcolepsy is a neurological problem that's been known about for a long time, although people were uncertain as to what caused it. But we all stay awake because of certain neurotransmitters. One particular neurotransmitter is called orexin or hypocretin, and if you do not have sufficient levels of that neurochemical in your brain, you're more prone to fall asleep. There's all degrees of severity, so that sometimes with mild cases, people are simply more likely to fall asleep during periods that might make anyone drowsy. But there's other individuals that are so hypersomnolent or so very sleepy that they're prone to fall asleep even while they're physically active. Because that chemical, orexin, not only moderates sleep, but also REM sleep or dream sleep, it's very common for people who have untreated narcolepsy to have unusual REM-related phenomenon. They may actually start to dream a little bit while they're still awake. We call those hypnagogic hallucinations because they have a certain fragment or bit of REM sleep even though they're actually awake at the same time. They may have what we call sleep paralysis. Normal individuals during REM sleep are either paralyzed or partially paralyzed. Probably a good idea so you don't get up and act out your dreams, which actually is another sleep disorder, incidentally, that some people do have. But sometimes folks with narcolepsy will fall asleep, they'll go into REM sleep, and then they'll wake up, but they'll still be paralyzed for a brief period of time. We call that sleep paralysis. And then the other component of narcolepsy is what we call cataplexy. But sometimes a stimulus such as being startled or being surprised or being made to laugh can precipitate REM sleep or REM while someone's actually still awake, and they get the atonia or the loss of muscle tone. And there are individuals, if they're startled, will actually simply become limp all over and fall to the ground.
Oh my goodness. So if you just feel tired all the time, that's not it. You have to have some really significant episodes.
Most people who are tired all the time either turn out to be having insufficient sleep or to have untreated sleep apnea. It is a minority of individuals that turn out to have narcolepsy.
And one of the things you mentioned was movement, and I'm assuming that would be like sleepwalking. Is that what you were talking about?
So there are individuals who will walk around in their sleep, and that can be actually two different things. There's a phenomenon called sleepwalking, very common in normal children. We don't really consider it to be a disease in children. And that occurs in a certain stage of sleep called slow wave sleep, which is a fairly deep type of sleep, but is not REM sleep or dream sleep. There's also a condition called REM behavior disorder. It's more common in older individuals, and it is where the normal mechanism that paralyzes you during REM sleep has become impaired in such a way that these individuals actually will act out their dreams. It's particularly a problem if someone is having dreams where they might be assaulted in the dream, or they might feel the need to escape from some dangerous situation. It can cause individuals with this to inadvertently strike their bed partner or to get up out of bed in their sleep and then trip and fall and harm themselves in that way.
So when As an example, my husband, when he dreams, he moves around all over the place. That is actually something similar to sleepwalking? Is that what you're?
It is similar in the appearance of it, but
Okay.
one of the say for instance, one of the issues with a in-lab study, we can actually see what stage sleep someone's in, and so typical sleepwalking, which might be treated in one way, occurs during so-called slow wave sleep, which is N3 or stage 3 and 4 sleep, whereas this other phenomenon, REM behavior disorder, occurs typically during REM sleep, and that would be treated in a potentially different way.
Okay, and one of the, because every time you say something, I can relate it to, to my own family history. You said in children, and it's quite often that you will see them sleepwalking, and it's almost normal.
Mm-hmm.
What causes that to happen?
I don't think we really know for sure what causes it. It may be a certain genetic vulnerability. You oftentimes see sleepwalking in the children of adults who sleptwalk when they were kids. The typical story is someone will sleepwalk quite a bit when they're little, and it'll become less and less frequent as they get older. Oftentimes, when they get older, it will only occur if they're very sleep deprived or if their sleep's otherwise being disturbed in some way.
Because I remember my daughter doing that and opening the front door and making the alarm go off when she was probably 8 or 9 years old, and she didn't realize what she was doing. Um, and I always thought that was kind of weird. But if that's normal for children, then she's not weird after all.
There you go. I'm sure she'll appreciate hearing that.
Yeah, well, she'll get me for that one, I'm sure. um, Now, when someone is, let's go back to the dreaming, and I'm not going to ask you to decipher dreams. But when someone is dreaming and they're moving and acting it out, should you wake someone up when they're doing that? Is it, or should you let them just continue? I don't know. With the stage of sleep they're in, what would be the best advice for that?
We usually don't recommend waking somebody up, and it's just as a lot of people have heard with sleepwalkers. It's not something when somebody is sleepwalking that you want to actually wake them up, because it can be quite terrifying. Because the person is asleep, they're in a different room, and all of a sudden they're woken up and they're standing in the kitchen and have no idea how they arrived there. So, but we do take we certainly take safety into consideration when making recommendations regarding what to do in those situations. So, especially in children, making sure that, especially if they sleep on a second level, that they're not able to walk down the stairs or even walk up the stairs. Having gates, locked doors, those types of things are very important.
What would you recommend you do if you find your spouse in the kitchen in the middle of the night sleepwalking? What would you do?
Well, I think first make sure they're actually asleep and not hungry in the middle of the night. Yeah.
Okay, I'll give you that one.
We usually recommend just redirection. Again, in children, this is very common, redirecting them back to bed, not actively trying to wake them up, but redirecting them back to bed and making sure they get back to bed in a safe manner.
I would just add also that if someone has been sleepwalking since they're a child and they continue to do it as an adult, that's not so alarming. If someone starts sleepwalking at 40 or 50 or 60, the other thing is at some point they really should, again, consult their physician. We do sometimes see that as a side effect of medications, but that can also be the first signs of various medical conditions too.
Like what kind?
Well, for side effect of medication, it's a fairly common side effect, unfortunately, of some of the sleeping aids that we use. It's most publicized in combination with one of the very common sleeping aids, Ambien or Zolpidem, but you can see it actually in conjunction with almost any sleeping aid.
Is that the medication interacting with your body? Is that what is happening?
It may be. There are certainly some people that are very prone to do it and other individuals who are very resistant to it. And so there may be, either genetics or whatever that predisposes some people to have that side effect and not other people.
So if you can't sleep and you take a sleeping aid and all of a sudden you start sleepwalking, that could be a result of it.
Absolutely.
Okay. Well, we need to take another break, but I want to continue this conversation because I'm finding out all kinds of interesting things about what my family has been doing while they're sleeping. So we're going to take a break, and I will be right back. Let me ask a question before we start back. Dementia. What does that do to a person's sleep? I mean, especially as it progresses and gets worse and worse.
Well,
Does that have any effect?
yeah, I mean, it does. I mean, people's sleep schedules can be very disrupted. The normal sleep-wake schedule can be disrupted. People tend to sleep more during the day. They're more awake during the night, and keeping a regular schedule is more difficult because of that.
I mean, the biological clock is the brain. And so anything that affects the brain is going to have an adverse effect on sleep. So any head injury, traumatic brain injury, stroke, Alzheimer's, multiple sclerosis sometimes, really affects individuals' sleep mechanism and can lead to their sleep being more fragmented.
Okay. I'd like to talk about that if that's okay.
And
And
of course, the dream interpretation, which is Dr. Ramey's.
I know that's why I threw that out there.
That's his
Area of
specialty,
expertise.
area of expertise,
That's why I asked it.
along with ink blot interpretation.
Yes.
And we're back with the senior moment. Again, this is Connie Clark with Home Helpers, and I have Dr. Coates and Dr. Ramey from the Kootenai Sleep Disorder Center. And we've been talking about a number of things having to do with problems with sleeping and different things that can affect it. And one of the things I asked during the break was if you've got a person getting older and they're having some dementia issues and things like that, would that affect their sleep patterns and how would it do that? And you all came up with some really interesting observations about that. How about explaining some of the things? And you were even throwing in some other medical conditions.
Absolutely. So in normal sleep, in all of us in sleep, if it's normal or not, the biological clock is in the brain. The brain sets the sleep cycle. And anything that affects the brain, that can be a traumatic brain injury, it can be stroke, it can be a degenerative disease such as Alzheimer's, or it could be Parkinson's or even multiple sclerosis. Those all affect the brain tissue and the neurons in the brain and can affect the quality of sleep. Generally what happens is that the sleep becomes more fragmented. It becomes harder to consolidate your sleep so that your sleep occurs in certain periods which are been separated by other periods of wakefulness.
So if someone is suffering from Alzheimer's, because I see this a lot, and now their sleep patterns have changed totally in that they're either, like you say, sleeping very long periods of time or in little pieces, would CPAP be appropriate for someone like that or no?
CPAP is really only helpful if someone does have sleep apnea.
Okay.
And so if someone becomes hypersomnolent, if they become too sleepy at any age, one of the things that needs to be considered is could that person have obstructive sleep apnea? I see people all the time who are in their 70s, 80s, and 90s and were not previously diagnosed as having sleep apnea and in fact turn out to have sleep apnea and are able to adapt to doing CPAP or a dental device, any of the appropriate treatments. Sometimes you see that, though, just as a product of the medical condition that the person has, and you can see that as a product of just dementia. If that's the case, there's things that we try to do, but they really need to be done in conjunction with the patient's caregiver. If an individual can be kept more active during the day, they tend to sleep better at night. If you can avoid naps during the day, naps are sort of the junk food of sleep. A little bit of junk food's a good idea, but too much isn't. And so if you can minimize the naps, both in the duration of naps and also control when they occur, a nap earlier in the day is less likely to be destructive of sleep than one in the latter part of the afternoon or in the early evening. So those are the things that we try to do to help folks get better sleep without necessarily throwing pills at them. There are some cases where you do really have to do pharmaceuticals to help people sleep better, but if we can avoid that, we like to do that, particularly in older individuals that are more sensitive to and more vulnerable to the side effects of medications.
And you had mentioned traumatic brain injury. So if someone has had a traumatic brain, and we had some people here talking about traumatic brain injuries a few months ago, and even the fact that someone could have one and not know it, or even a stroke, which is actually a traumatic brain injury. If someone has that, should they expect to start having sleeping issues?
Well, it's not guaranteed that they will, but we just know that with those types of injuries, more so traumatic brain injuries due to whatever reason, that sleep disruption is common. And that's usually something, depending on the severity of the injury, that can improve. It's not necessarily a permanent problem. It is something that is commonly seen shortly after the trauma, but tends to improve over time depending on the severity of the trauma.
And I have to ask this. If you've got someone with Alzheimer's and you find them wandering in the living room in the middle of the night, how can you tell if they're just wandering or if they're sleepwalking? Is there a way?
Well, you can try to gain their attention. Somebody that's sleepwalking may appear awake, but they're really not going to respond to you. May not respond to their name being called. Their eyes may be open, but they're not probably going to respond. Whereas somebody that's just wandering will have some degree of responsiveness, probably.
And so that would be the difference is when you talk to them, they won't respond if they're sleepwalking, correct?
More commonly, yes, they will not.
Because when you were talking about brain injuries and stuff, I thought, well, a lot of times people with Alzheimer's get their days and nights confused. Mm-hmm. And so they're up at all hours of the night. So how would you know if they were sleepwalking or if they were, just wandering? When someone is sleepwalking, let's go to the extreme here. Can they go out and get in a car and drive and things like that while they're sleepwalking?
Absolutely. I mean, that's a major problem with sleepwalking, and that's one of the reasons why it really does need to be addressed. Children are less apt to do that because driving isn't one of their normal behaviors, but they still are prone to maybe leave the home. Most people who sleepwalk don't hurt themselves if they don't leave their bedroom. Some people hurt themselves if they leave their bedroom, some people don't, but once you go out the front door, anything can happen. And so I do recommend that if someone in the family sleepwalks, that there be an alarm on their door and also on the door for the house, the exits of a house. One thing to remember is when individuals do sleepwalk, if it's true sleepwalking, they do tend to be in a very deep stage of sleep. As Dr. Ramey said, it's very hard to wake somebody up that's sleepwalking. The alarm oftentimes doesn't wake up the sleepwalker, it wakes up their family.
Right.
And that they're able to come to their assistance. But if someone in the home sleepwalks, I mean, the doors and the windows should be secured. Like I said, I like the idea of alarms on the bedroom and the exits to the home. And then, of course, anything that's potentially, dangerous should be secured. Car keys shouldn't be left out.
Now, if someone wanted more information about sleep disorders, if, they're not taking any other medications or anything like that, and so they're not having any adverse effects, what should they do?
Well, I think there are several things that they could do. Again, if I could put in a plug, I think it's always appropriate to discuss this with your primary care provider, your family doctor. Many people come to us refer to actually now, when they mention sleep problems to their dentist, they'll bring up snoring. And so I think to bring it up with a provider that you're comfortable with is a great idea. Individuals can certainly contact the sleep lab at Kootenai Medical Center. We have a technician there during the daytime. The other source I think is a good source of information is the National Sleep Foundation. It's an organization of people involved in sleep from all fields. They don't have any commercial bias. It's not sponsored by a pharmaceutical company or a CPAP maker or or anybody else. It's mostly made up of academics that study sleep. It's called the National Sleep Foundation, and if you just Google that, you'll come up with their website, and they have loads of common sense advice that I think is helpful for people about insomnia, restless legs, narcolepsy, sleepwalking, the whole gamut.
So if you want more information, you can always go on there, and you can always call the Kootenai Sleep Foundation or the Sleep Disorder Center. Are you located there with Kootenai Medical Center in that same complex?
The sleep lab itself is in the medical center, and it's in a part of the hospital that's otherwise used for more administrative purposes, so that at night it's very quiet. It's not on a ward, so there's no hustle and bustle. And
Lights
and
aren't
things of
on
that
all the
sort.
time. Okay.
Exactly.
Okay.
Dr. Ramey in my office is actually in the Interlake Medical Building, which is across the street from the hospital. So
Oh, okay.
we're adjacent to the hospital, but not in the hospital.
Okay, and I have your phone number on here. If you wanted more information, you can call 666-2894 or 666-2920. And you can also go on kootenaihealth.org/sleep for more information. Well, thank you, gentlemen, for coming on with me this afternoon. It was very, very informative. If there was any last words that you'd like to say, what would they be?
I would say this. I think sleep is very important. There's nothing that makes people feel better than a good night's sleep. And I think that sleep isn't just, though, feeling refreshed, although that's very important, but untreated sleep disorders, particularly untreated sleep apnea, does actually have a significant increase in mortality. People with untreated sleep apnea simply do not live as long as the general population. Part of that is because of the increased risk of heart disease, and part of it with any sleep disorder is that drowsiness is a problem. It causes increased automobile accidents. It's not just falling asleep driving, but drowsiness itself can be an impaired form of driving.
I would say that sleep is something we all do. We all do it a little bit different. We all get a little different amounts, but it's important for all of us. And I think for a lot of sleep disorders, if you're starting to have problems, it's best to have that discussion early, especially with your primary care doctor, because as people have problems, they tend to engage in more maladaptive behaviors that can just further the problem over time.
Like taking sleeping pills.
And given, as Dr. Koch mentioned earlier, that it goes beyond the sleep. There are some sleep disorders, particularly sleep apnea, that are a significant risk factor for having other health problems in the future, like high blood pressure and heart attack and stroke. So if there's any concern, it's best to have that conversation early with your primary care doctor so they can point you in the right direction.
Well, thank you very much. I appreciate your comments. And again, if you have any questions, you can give them a call or the National Sleep Foundation.
Yes.
Go Google that, and you'll find all kinds of information. So thank you again for joining me this afternoon, gentlemen.
Thank you for having us.
Thank you.
And you've been listening to the Senior Moment, and you all have a wonderful rest of your afternoon. Good day.